Well, good afternoon. I'm Beth Stewart, and on behalf of the Texas Oral Health Coalition, I would like to welcome you all to the first webinar in a 3-webinar series by Dr. Mark Bullock. Today's topic is providing dental care under advanced anesthesia, oral sedation, IV sedation, TIVA, IV MAC, and general anesthesia. Please mark your calendars for his next 2 presentations on May 13th, when Dr. Bullock will be presenting on special conditions, barriers, and challenges providing dental care to patients with IDD, and on August 12th, understanding and working with caregivers in group homes and dental desensitization, advanced behavior techniques for patients with IDD at Abilene State Supported Living Center. Our presenter today is Dr. Mark Bullock, a special needs dentist and dental director at the Abilene State Supported Living Center, a state facility for individuals with intellectual and developmental disabilities. He previously served as the Chief Dental Officer for Mercy Ships, providing free dental care to the people of West Africa. After earning his dental degree from the University of Texas Dental School in San Antonio, he completed a 1-year Army residency in advanced general dentistry. Driven by a passion for underserved dental patients, he takes pride in providing comprehensive and compassionate dental care to patients with complex needs and challenges. As a special needs dentist, his goals include improving access to quality dental care for patients with IDD. It is with extreme pleasure to welcome Dr. Bullock.
Hello, everybody, and thank you, Beth. So first, we've got to start with some disclaimers. There we go. So I have no financial interest or conflicts of interest in anything I'm about to talk about. Another big one is these slides represent my own opinions, some biases, but I am not speaking for the state of Texas, the Health and Human Services Commission, or the state supported living facilities. These really are just my own opinions and experiences. There are no product endorsements if I'm good and don't say any product names. So if I do accidentally mention a product name, it's really just for demonstration purposes. There are a lot of products out there. So about me, I have no real special training or degrees. I'm not an academic. I do a little research when I can. I'm very much a clinician. Basically what I'm talking to you today is my experience over the last 7 years working at Abilene State Supported Living Center. So please take it with a grain of salt. Standards of care guidelines, best practices, and policies. I'm going to kind of talk around those words a little bit, but I'm not in any way trying to set standards of care. I don't make guidelines. I don't, if I put up a name of an organization, I'm not speaking for them. I'm really just giving my best interpretation of what I feel like they're saying. I don't go too much into rules and regulations. I'm not a lawyer. We are talking about anesthesia, so there are a lot of rules about this. Please don't say, well, Dr. Bullock said to do it this way, and do your own research. And then my last disclaimer is time. I'm hopefully not going to run over today, and I really could talk about this probably a lot longer than a lot of people could stand hearing me talk about it. But if I do start whipping through some things really fast, it's just I'm trying to keep us on time, and I hope it's part of a much longer conversation we have in the future. So what are my objectives? Here's where I'd like to go with this is really just defining what I mean by advanced anesthesia, discussing the role of advanced anesthesia with patients with IDD, our role as the general dentist. And at the end, I hope what you get out of here is I'm really trying to advocate, I don't specifically have a slide on it, but really advocate for safe and effective comprehensive care for all patients with IDD. So please, if I ruffle any feathers, I hope my intentions are good. So I wanted to start out with a little poll here, just if y'all don't mind. This would be largely for my own interests. I'd really like to know what y'all all believe is the biggest challenges providing dental care to patients with special needs. I had to give some choices, so I kind of came up with the 4 I thought were the most likely to be, but I really am interested in if these 4 kind of cover everything, or if there's a 5th, I'll give my contact information in email and be like, nope, no, those weren't even close. Here's why I don't, or do or don't, or treat people with IDD, or I do treat people with IDD and I find these challenges. So we'll just give a couple seconds there. This wasn't really a large discussion point or a part of the presentation. We're talking about anesthesia today, so this was just more for my own personal interest. All right. Well, y'all go ahead and if you like to answer that, but I'll move on. We might revisit this at the end if we have some time. So, oh, there it did pop up. Yeah, so expertise are not comfortable. Okay, well, hopefully this presentation or this series will help a little bit with that. So, very good. So moving on, click forward there. There we go. So I want to start with a few definition. This SHCN is what I found from the pediatric dentists, mainly out of this special needs care needs 2021. It seems like to me the pediatric dentists in our profession are kind of the authority on individuals with developmental disabilities, especially the children. So I thought this definition was important, but it is a very broad definition. Reading the guidelines, special health care needs kind of covers anything, asthma, wheelchair, I think even geriatric would be considered special health care need. So it has a lot of scope to it. I think they're mostly talking about children or they are talking mostly about children in the guideline. I don't use this term so much in our facilities. We use more the term IDD, which stands with individual with developmental, intellectual and developmental disabilities. Got to get it all out there. But I'll kind of use them interchangeably. In my job, we do have patients that are older, so some geriatrics, but I'm more speaking to the IDD if I say special needs, so please forgive me. I did throw up this number here because as you can see, there's a lot of people I really believe out there that fall under special needs or IDD. So they're out there. I think if we're not seeing them, it's just because they're not walking into our offices. So one in 4 children are significantly impacted. That's a lot of kids, and then those become adults. So that's kind of the scope of it. So moving on, advanced anesthesia. You're probably not going to find that written a lot of places. I've kind of coined it. I don't want to say I've coined it, but what I call advanced anesthesia is really pretty much anything beyond local anesthesia. So when I say that word, that's kind of what I'm talking about. Nitrous is not really useful in my practice. It kind of, whether you call that advanced anesthesia or not, I mean, I think if you're using a little bit of nitrous to do some fillings on somebody under local anesthesia, probably not advanced, but if you're using nitrous to induce somebody into general anesthesia, then it is advanced. So nitrous is kind of gray area, but largely advanced anesthesia, I'm talking about these kinds of words. So with advanced anesthesia, and I have had some complicated conversations with people concerning advanced anesthesia because it is kind of a continuum. We can really agree the difference between oral sedation and general anesthesia. Okay, oral sedation, they're awake, maybe drowsy, but they can talk in their own airway. That makes sense. General anesthesia, they are out. There's a tube in, gone. Like those are obviously different. So it's more this little area in the red where I think kind of the conversation can get really muddled really fast. TIVA was just getting kicked around as a term when I left dental school. It seemed like the hot button term everybody loves now. Like, oh, do you do dentistry under TIVA? Well, TIVA can encompass quite a lot of even IV sedation. It can start of TIVA all the way up to putting a tube in under TIVA. That word IV Mac I throw out there just because in my experience, it's more used in hospitals among our medical brethren. I don't use it a whole lot. I don't do IV Mac cases at the hospital. I work at a hospital, but I really just want to throw it out there because if you do start treating special needs people at a hospital, it may be a word that comes up. You know, somebody may ask you why you're not doing IV Mac. You might just want to be familiar. MAC, by the way, stands for Modern Anesthesia Care. So that's what it stands for. Basically, the continuum is based on these criteria down below. Our board is level of consciousness / root. It's a little bit of both, as we all know. Sometimes you'll hear about stimulation, you know, are they arousable? You know, general anesthesia, not aroused, you know, pain, no pain response whatsoever. Sedation, they should still react to stimuli. Airway, open airway is more sedation because they're maintaining their own airway. General anesthesia, they got a tube in. Pretty much everybody agrees on that. The last one was specific medications. Again, so our board defines ketamine as a general anesthetic. So if you use it, are you doing general anesthesia? Our medical brethren sometimes don't understand that because ketamine in there is a really good sedative. I mean, it's a dangerous one, but primarily used on horses at one time, but it is a sedative. So again, that's where kind of dentistry and medicine, we can kind of get lost in the weeds a little bit. But when I say advanced anesthesia, I'm talking about all of them. We're going to start a little more depth into sedation. PTS, you'll see, has a lot of definitions. Typically, it means pre-treatment sedation. We use it for pre-treatment. We use it for treatment. Out here where I work, we also use it for call it preoperative sedation, you know, before an operation, pre-procedural operation. And then my favorite is we do use it for pre-IV sedation. So it can be oral or IV, as we all know, and, you know, we're taught that in school. Again, we know oral is not titratable, whereas IV is a little bit titratable, meaning you give them a pill, that's all you get. Don't recommend giving more, but some people do. So I guess it could be titratable that way. But the way I learned it, it's really not. Whereas IV, you can give a little Ativan, that doesn't do you good. You can give a little more, kind of in real time. I'm not going to get too much into the permitting. I think as dentists in Texas, pretty familiar with that, especially if you do it, you're going to know what level permit it is, but you do have to be permitted to do oral. You have to have another permit for IV. In my opinion, in my practice, when you're talking sedation, where the patient's arousable, you're generally talking about a patient that's cooperative. If you're trying to use, especially oral sedation, to take somebody who's completely uncooperative, I think that's where the most problems have come up, is when you're trying to use sedation on somebody that it's just not intended for. So be careful with that. And I know a lot of people say, well, that's all I can do. Well, I do understand that. And we're going to talk more about that. It's one of those problems, definitely. Sedation can be used alone. You know, like I said, on a generally cooperative patient, you can get a filling done. It can help them relax, make them a little more cooperative, maybe, but it's more about making them more comfortable. It can also be used in combination with some of the other types of anesthesia. In fact, with patients with IDD, oftentimes just get them in the building. You really want them to have some oral sedation on board, and that's very commonplace. So even though you have a level 1 permit and you're not using it for treatment, you may be using it for pre-IV. So it might be good to have. Don't get rid of it. Just wanted to throw out for everybody, don't forget nitrous is its own permit. Read your board rules. You got to have a special class and get permitted for that. So do be careful. You know, it's not like the old days. So, all right, I'm already a little behind. I apologize if I start speaking fast. I apologize. But moving on to TIVA versus general anesthesia, or TIVA / general anesthesia. So TIVA encompasses a lot of things, right? Gas versus IV. So when you say the word TIVA, you're meaning IV only, which means no gas. So the gases are typically sevoflurane is a medication I'm most familiar with. I know there's a bunch of others, but I'm not an anesthesiologist. It allows you to put on a mask, like a nitrous mask, and put somebody basically to sleep before you put in the IV. At least that's how my anesthesiologist who does gas anesthesia uses it. It's really good. It's more typical in children, much like IDD, because they have problems with IVs. You mask them down, put in the IV, and then go from there. Now with TIVA, by definition, you're not using a gas, so you're going to have your IV in place before you can give any medications, theoretically. That's why a lot of times oral is used in conjunction with TIVA, is because you already have something on board to help them be more cooperative with the IV. Airway. So general anesthesia, you have a protected airway. If your airway is open, you're not doing general anesthesia typically, which is something to know, because if you're doing gas anesthesia and you want an open airway, there might be reasons to do that. Then you're not going to be doing gas anesthesia. You're going to be doing TIVA, and you might want to be familiar with that kind of as in your case selections. So, what is it for? So TIVA, IV sedation, TIVA. So if I say TIVA, I might be kind of more on the IV sedation side. You have a little more freedom moving along the continuum, like I talked about. But what is general anesthesia for? Well, we'll get into more in that, but I'm going to throw out some words like advanced procedures, painful procedures, long procedures, diagnostic procedures. There are reasons to do diagnostic procedures using general anesthesia. It's not uncommon in medicine to get diagnosed under general anesthesia. Kind of in dentistry, we always feel like we got to get a lot done under general anesthesia, but it's not outside the realm, but we'll get more into that. So why not always use this? It is definitely difficult. Like, it's nice doing work and the patient doesn't have to go to the bathroom. They're not going to fight you, but there is always the risk versus benefits analysis. And we'll get more into that, but you do have to be careful with that in general anesthesia. There is a slight danger. It's very safe. I always tell patients, I looked it up, the NIH has a study, it's about 1 in a million as far as complications. The numbers are actually pretty close, which I always found interesting. But there is always that added bit of risk there. So I now like to talk a little about airway, because I don't feel like we talk a lot, or I didn't get a lot of talk about airway in my dental school. And yet it's so important. I mean, yeah, we all know, we were told don't drop a endodontic file down there. That's for sure. But the reason airway is so important with patients with IDD is that IDD patients have a compromised airway when fully awake. It's a very complex, the swallow is a very complex system. And usually if they have higher brain function disability, along with tactile, hand-eye coordination, swallow goes early. So just be aware of that. If you're working with people with IDD, I think we need to really be considering airways. And then if you add sedatives on top of that, you're compromising airway even more. So bear in mind, what are the types of airway? Well, we have open. That's just open. It's open right now. That's typically what neurotypical people get their dentistry done under. Intubated, that means they've got a tube past their vocal cords. I hope I'm not upsetting anybody by talking down, but I didn't learn these things in dental school about what intubated was. LMA, that stands for laryngeal mask airway. I only recently, well, since I came here 7 years, they weren't real big. I learned a little about them in the Army because we had trauma training. They're used in trauma. Basically, they don't go past the vocal cord, but they kind of cover it up and seal it off to a bit. They're not as safe or secure in airway as intubated, but they are a little easier to place, as well as they require less anesthesia to place them. You don't have to be fully out. You're definitely out, but not as fully out as intubated. So with whatever airway you're using, especially open, high volume suction and an assistant is how you protect that airway. And I can't stress that enough. High volume suction and assistant, even my hygienist uses an assistant in high volume suction for our high risk patients here, because that's how we protect their airway when it's open. So, which type of anesthesia should be used? Again, this is the world according to me, but these are the kind of things I think of when I'm deciding what kind of anesthesia to use. Some of it has the severity of IDD. If they are very uncooperative or physically can't cooperate, even for the most simple things, you may be fully general anesthesia. If they have a very compromised airway, sedation may not be an option, not because it wouldn't work, not because they're generally cooperative, but because it wouldn't be safe to do so. So you may be under general anesthesia just because of the severity of their disability. How long is your procedure? Are you going to adjust a crown under general anesthesia if you don't have to? A little light sedative if you can, rather than going to the full length. But the length and invasiveness kind of need to be taken into consideration, because longer the procedure, you're going to be safer under like general anesthesia. Now, what's long? In dentistry, long is 2 to 4 hours. I would say 4 hours is very long, but do know if you go into the medical hospital, 4 hours is really a short type of surgery, or can be short. So we'll get more into that, but just know length of procedure can make a determination. If you need a protected airway, if you need a patient intubated, you're going to be in general anesthesia. Routine versus emergent care. If somebody really needs something right now, general anesthesia takes time to plan. Are you just going to move forward with a mild sedation, and even though they're maybe not so cooperative? That's what I mean by routine versus emergent. Available resources. If you don't have access to general anesthesia, it ain't an option. Sorry to be colloquial about it, but and then that brings me to my last point, is perceived safety and equals hospital. There's this prevailing idea that general anesthesia at the hospital is the safest. This always concerns me, because if you have a complication in your office, somebody may ask you why you weren't doing it in the hospital. Not saying you need to do all cases in the hospital. We don't want to overwhelm them, but you need to think about, well, is this the kind of case to go to the hospital just because of the safety? Even though, in my opinion, the hospital is not always the safest place for cases, but that is prevailing out there. So if some of you are asking like, oh, Dr. Bullock, you're Ivy Tower, you're recommending doing everything for everybody. I'd like to, but I wish we could do that, but no. When we're talking about patients with IDD, there are some reasons why we don't. What does comprehensive care even mean? I mean, that's probably a conversation we could have in and of itself. Well, when I say comprehensive care, I mean doing everything you would do to a neurotypical patient, regardless of money. Full periodontal, full diagnostics, probing, periodontal probings annually or whatever frequency you believe they need them. Full periodontal care, implants and bridges. This is important because a lot of times patients with IDD didn't get comprehensive care because of their cooperation. I think those days are going away, but I feel like they are, and I want to see them go away. We should no longer be saying, well, they're disabled, so they don't need that. But at the same time, we don't overtreat. Patients on a pureed diet because they have aspiration issues, are you going to be really putting them under general anesthesia to do a full mouth rehab case? So just because you have access to general anesthesia or advanced anesthesia, should you use it should always be in your mind. Moving my next is, I put the picture of the ogre up because I always feel like an ogre when I talk about life expectancy. When you're working with patients with IDD, Unfortunately, we have to take into account their condition and their life expectancy. Some conditions reduce the life expectancy significantly. Are you going to do full periodontal therapy and management on a patient that's already 5 years past their life expectancy? Is managing their periodontal disease going to benefit them? You kind of need to ask yourself those questions, especially when the risk of anesthesia are involved. But I have down here, don't be an ogre too. Many patients with IDD live very long lives. So don't just say, oh, well, they're disabled, they're going to die early. No, a lot of them lived 70s, 80s, 90s. And unless you have a reason, I encourage you, unless you have a reason to suspect their life expectancy is shorter, pretend like they're going to live a nice long life and do your best. So moving on to the next section of my topic is the roles of advanced anesthesia in dental care. Mainly, I see advanced anesthesia as advanced behavior management. Now, this comes at odds with the Texas State Board because the board rules say in order to give somebody a sedative or anesthesia, they don't say specifically, but dental anxiety. And so we diagnose everybody with dental anxiety. I feel like because the board tells us we have to, even though really they're not anxious, they're just uncooperative. But is that a sign of anxiety? I guess it could be, but this section of the talk is moving. We're going to talk a little bit about guidelines, case considerations, and a few of my experiences, and then I'll do some tips and tricks in this part of the talk. Guidelines. Real quick on guidelines. I've had a hard time finding real concrete guidelines for the use of anesthesia in patients with IDD. The pediatric people, the APD, they do have a guideline with the management. They talk a little bit about the management of dental patients. Of course, it's children focused. The anesthesiologists, that's the ASA, they have some loose guidelines. I don't really specifically talk to people with IDD. The SCDA, Special Care Dental Association, which I'm not a part of, but they have some helpful information. I didn't find specifically a lot. The ADA, I haven't really found any specific guidelines, but the new code, they updated quietly, and I just want to throw this out because it seemed a good place to throw it in, which explicitly prohibits dental care providers from denying care to patients because of their disability, and also specifies that patients with disabilities in need of another dentist skills, knowledge, or equipment expertise should not turn away and should instead be referred. Of course, the problem is refer to whom, and I hope to see that change. But anyway, just know that's out there now. I put this paper down here in the lower corner, dental treatment or general anesthesia for patients. It's not guidelines. What it is it's a study of all the reasons patients with IDD have been put under a general anesthesia. And I kind of felt good because it was like, okay, yeah, most people are doing it like we're doing it. So that's a good paper, but they're not guidelines. What I see advanced anesthesia is primarily doing is it's replacing or supporting protective stabilization and moving us away from the bad old days. I have this dinosaur here because the bad old days were just strapping people down and getting it done. Words like physical restraint, mechanical restraint. We don't want to see those days come back, but the only alternative that I know of to help somebody cooperate is advanced anesthesia. So that's primarily what I see advanced anesthesia role is so we don't have to rely so much on some of those older mechanisms that we as dentists used to rely heavily on, solely on, because that was all that was available. So it's definitely the right direction. Case considerations. What am I thinking about when I'm picking cases? Kind of all these things. ASA classification is in the board rules now. They actually made it part of it. I really like it. It actually does work out well. The only problem I have with it with patients with IDD, and I just want to review it real quick. ASA 1 is normal healthy patient. ASA 2 is mild systemic, which they base on function. So minimal effect on function. Well, a person with IDD, especially if they're living in my facility, already has compromised function. So does that make everybody an ASA 2? That's plausible. ASA 3, severe systemic, limits activity, but it's not incapacitating. And then it says, i.e. prevent from functioning in a normal way. Again, patients with IDD in a wheelchair, they aren't walking. They're not functioning in a normal way. Does that make them automatically an ASA 3? I do talk about this a little in jest, but at my facility where I work with, I had to really work through this because of we have patients with G-tubes, relatively healthy patients with G-tubes. If you don't know what a G-tube is, a gastrostomy tube. Out in private practice, you probably don't see these because a lot of these people would have to have nursing care or nursing home care. But how healthy are they? Well, with a G-tube, are they a 3, a 2, a 4? I mean, I probably do some things on people that live here that might stretch the imagination, but because of the environment they live in, they're very healthy ASA 3, but if they were living out on their own, they probably would be a 4 just because of the way they're managed. ASA 4, by the way, and 5, incapacitating. ASA 4 is incapacitating disease. I don't do routine dental care on ASA 4 or 5. Of course, 5 is in the hospital, so we don't see those at all. But moving on, some other considerations, weight and BMI is very important. High BMI, we'll talk a little bit more about some of these. Airway molempody, again, like we're talking about with patients with IDD, may have skeletal deformities. You have a poor airway. You have to take that in consideration. G-tubes, like we just talked about. Preoperative behavior, if they're not cooperative, even come in the office, kind of oral sedation is probably not the way to go. Might get them in the door, maybe, but just long enough to get an IV in them. So, I do take into consideration how uncooperative they are. But if they're very cooperative and they just need a little help, maybe we're talking more oral sedation. Wheelchair bound. In my opinion, anybody who's wheelchair bound has a compromised respiratory system, and you need to take that into consideration. Paraplegic, who's in the Olympics, maybe, but even then, somebody who's in a wheelchair is not taking full deep breaths as somebody who's walking around. So I do take a special note of somebody who's wheelchair bound, and with patients with IDD, that's much more common. So just some of the things that I learned over the last 7 years to be really cognizant of. Urinary retention. If somebody has urinary retention or constipation or a history of obstructions, the reason these are important is because they're the most common complications after anesthesia. And I'm primarily talking about general anesthesia and TIVA here, not so much oral sedation. But, you're giving anesthetics to somebody who already has these problems. Don't be surprised if you have this problem and be ready to manage them. So history of pneumonia is a big one here. So if a patient has ever had pneumonia, their risk of getting pneumonia is higher. It's one of those kind of conditions. If most of my patients with a history of pneumonia go to the hospital, now I'll caveat that with they had pneumonia when they were a baby. A lot of patients with IDD have childhood pneumonia. When I say childhood, I mean baby. And really, they develop out of it and they don't have it again. I mean, take that into consideration, but it may not mean as much in that context. But if they've had several pneumonias over the last 5 years or within the last 5 years, be very careful. Low body weight. I've learned to be very careful with especially young ladies under 100 pounds. Feel like there's something at 100 pounds where you just don't have the physiological reserves there. So be very careful with the small, especially female. That's been the problem patients I've had under 100 pounds. I said I'd go over BMI of a 40. Be very careful with that has to do with physics. So once you put them under anesthesia, whether it's sedation or what, all the support for that weight goes away. So what you have a problem with is collapsed airway, collapsed respiratory reserve, cardiac. Even all that weight can kind of put more pressure on the heart and make it harder. And they, like when they go under, they tend to bottom out real fast. So over 40, of course, obesity is over 30, I believe, but definitely 40. Ejection fraction, I want to talk a little bit about that because I've had some run-ins with that. Technically, over 50 and above is normal. 40, you have to kind of beware. Less than 40, I don't do routine care on less than 40. The big thing for people, I believe, in practice is if a patient or their caregiver knows their ejection fraction, start asking a few questions. You usually don't know what your ejection fraction is unless you've had a problem. So if you see something written, ejection fraction of 51, even if it's normal, like I said, even if it's normal, hey, why are you having your ejection fraction checked? So history of poorly tolerated anesthesia. Obviously, they've had complication with anesthesia in the past. They're at higher risk for it in the future. Although be careful with that. Not all anesthesia is good. It may have just not been done well, but do take it in. It's a warning. So be careful. Age versus medical age. This patients with IDD have a medication list at 45 like they're 75. So are they more like the 45 or more like the 75-year-old person? A lot of the guidelines you'll see based on age are based on typical people, 85-year-olds and below are considered same medical risk. Well, I have patients that even though they're 45, they very much are like an 85-year-old. So dysphagia, that's poor swallow. These are your patients that are going to aspirate either before, during, or after care. I didn't learn a lot about dysphagia in dental school, but look it up. It's a thing. And if somebody says I have severe dysphagia, take it as a warning. Acute versus chronic conditions. So general anesthesia, a lot of the guidelines written by the AAPD are for children. Well, the problem with that is that children primarily in dentistry deal with acute problems, cavities. So what over the last 7 years, I've really had a hard time, like how you use general anesthesia to manage periodontalgia, a chronic condition, where it's not just one and under and you're done. And I'm moving along pretty fast here because I'm watching my time, so I apologize. But endodontics, a lot of times patients with IDD don't get a lot of endodontic care because nobody will do it under general anesthesia. So a lot of the tooth gets tended taken out. But you can use general anesthesia. It's actually really nice. My endodontist loves it, doing it under. And of course, restorative care for general anesthesia. Local anesthesia, and I'm talking about in the context of using it with general anesthesia, to use it or not to use it. I've had anesthesiologists look at me like, you don't need to use local anesthesia. I mean, you do have to talk with your anesthesiologist about whether you're going to use it or not. So a lot of them are like, do, don't, it's up to you. My anesthesiologist, Dr. John Holt, gave me the best wisdom I think has ever. He said, if it's going to hurt after, he really recommends using it. Okay, so what that means is you don't have to use it all the time like we do on awake patients. You're just going to put a band on and pinch and, it hurts. But you don't need it for that. But if you're going to be taking out a tooth or something, they're going to be a lot more comfortable. I love local anesthesia. It helps with postoperative pain management. We don't use it for deep scale and root planing, again, because I wouldn't expect that to hurt after. Root canals, we typically don't use it. But if your endodontist loves going way outside the apex, and is going to cause a lot of postoperative concerns, maybe you do use it. When would you not use it? Patient, when induced and under general anesthesia, is already running at a high blood pressure and having tachycardia. So if you look over at the monitor, even though your anesthesiologist may not be concerned, but they're already really high, you might, in that case, ask, hey, should I use a little bit of this, a lot of this? Blocks. We do blocks, but do know patients with IDD, even adult ones, they like to chew their lip, like with the kids. So if you give a lower alveolar block, I've had chewed lips. I've had patients where I'd rather them chew their lip than run around tearing up the PACU. With patients with IDD, you just have to make those decisions, and sometimes they're wrong. The lips always heal great. Mom's always upset, but let's move on to types of airway. Again, this is something I didn't get a lot of in dental school. If you did, I apologize. But nasal is what we love in dentistry. It gives the whole airway to us. But you're going to find a lot of anesthesiologists can't get it in because it's an extra movement, or sometimes they're just not comfortable with it. So oral may be all you get, but it does change how you're going to need to work. So it's a conversation to have. LMA is oral only. So if an anesthesiologist or, say I got to pop in an LMA, you're going to have a very large tube in your way. So just know, that's why I kind of brought up LMA, so you know about it. It may change. If you're going to do a crown and you got to check a bite and there's an LMA or an oral airway in, you're going to have to think around that. So the type of intubation is also something to take into consideration. And I am way behind. I apologize. So some tips and tricks I've learned over the years. Throat packs. A throat pack is really just a gauze that's placed in the back of the throat. With an intubated patient, they would go tube throat pack. An open airway, you can still have a throat pack. If they're a little out, you can push something back there. But learn from my experience, use real medical throat packs. The reason they have they have bands in them that will show up on the radiograph. Now, I've had a hard time contemplating how somebody would ever ingest a throat pack in dental, especially an intubated patient. But I've had some sleepless nights where the patient was having some throwing up issues. It's like, well, the only thing it could be is a throat pack, and it wasn't. I have not had this problem, but thankfully. But do use throat packs. They really help protect you. If something is ingested, but you had a throat pack, how did it get around the throat pack? Well, at least you had a throat pack. Bite blocks. They're not going to be able to stay open. I think it goes without saying. But if you're planning a case, don't forget your bite blocks. You will save you or your assistant's hands trying to keep them open. Regular bite blocks. Mole clamps work really good. I learned that in residency. That's that old thing that you learn in pediatrics. Those work really well. Suction. Like I said, a lot of suction. I really just threw in suction. I'm not supposed to say a product here. They make combination bite block and suction. I think for anesthesia, especially open airways, and your anesthesiologist is comfortable with using it, I love those. You get an extra level of airway protection because you have a flap across the airway. You get immediate suction and bite block all in one. Look them up. They're really great. There's several on the market now. Ergonomics in anesthesia. Depending on the type of anesthesia, you may not have ergonomics, especially if you've got an open airway. I would really encourage you to consider, don't tump them all the way back into Ventrell position. Remember, your airway is already compromised because they're sedated and because they have IDD. Consider doing them a little more upright, a little less rolling back, a little less chance of aspiration. Now, if you're intubated, move them wherever your anesthesiologist. My anesthesiologist, like, yeah, of course you can move them. So you might have, if you have ergonomic problems and where you need them in a specific place, maybe you're considering more general anesthesia than an open airway case with sedation. Impressions. Impressions under general anesthesia. You definitely can do them. It's an added level of interest. And I'm watching my time here, dang. You just got to manipulate yourself. Triple trays, you can do them, but know you're going to have to compromise how you get in. That moves into occlusion. Hand manipulation of the jaw is really the only way you can get occlusion. So if you have a patient, you're never going to get perfect occlusion like that. We just manipulate in. And that's worked fairly well. I haven't actually had too much problem with poor occlusion, so it works well. General dentist role. I'm going to kind of talk about these are all my opinions. What is the general dentist role in general anesthesia? I really personally reject the lone wolf idea that I feel like is prevalent in dentistry, is that like if you can't do it, then it's not done. I don't like that. I think the best we provide is when we do it together. So I highly recommend finding an anesthesiologist, even if you can do the anesthesia. Now, again, I know I work in kind of an ivory tower situation. I also don't have a personal interest. I don't want to be an anesthesiologist. I never wanted to get my IV certification. So having an anesthesiologist, let him concentrate on the anesthesia, so you're free to concentrate on other things. Now, I do understand that you don't have to do it long, but you may have to, depending on where you're practicing. I really would like to see this change and more anesthesia services in dentistry come about, especially with patients with IDD. I think it really is the gold standard. But a little talk about dental versus medical. I have a bias towards dental, just because they understand dentistry. I've worked with some medical anesthesiologists that are great. You can definitely get a good one. Work with one if that's all you got. But again, a plug for my dental anesthesiologist. Both of mine are really great. So learning to talk to an anesthesiologist. So your role as a general dentist is, my opinion, is learning to talk to them, which that's why I appreciate your interest in this lecture, is because I think we need more than what we get in dental school in order to communicate with an anesthesiologist effectively. And that's how you make it a team good communication. So talk to your anesthesiologist about what you're capable of doing, what he's capable of doing. What are your capabilities? What's your background? What personnel do you have or your anesthesiologist have? So that's where you need to talk to them. Some anesthesiologists may bring an RN into the room, but if he doesn't have one, he may appreciate your help. Kind of holding an arm, doing an IV. If you have a great assistant that is familiar with a patient, those are all things your anesthesiologist and you kind of can make it a more effective and enjoyable experience for everybody, and safer, of course. So unfortunately, there's not a lot of dental anesthesiologists in Texas. We don't have a program for dental anesthesiology. Gosh, I wish that would change. It's a fairly small group of people, so likelihood you will be working with a medical anesthesiologist high. Be sure and read your board rules, because they're probably not going to know them. That's been my concern with medical anesthesiology, with all the new rules that the dental board has put out, is if you have a complication, are they going to be there standing next to you knowing the rules? So just take that in consideration. Hospital or office. Like we talked about, what's available. Do you even have a hospital that will let you work in it? Your office may be the only option. What is advisable? You have a medically infirm patient and you don't have access to a hospital, you may be wiser not to take that case. In my opinion, and I know, again, I'm the ivory tower dentist, I think to really provide the most care to the most people, you ought to be looking at both. How can I do this in my office? But also talking to your local hospital, if that's an option, about getting credentialed there. I know that I can tell you right now, some hospitals are open to that, some are very much not. We as dentists are kind of, don't make sense to them. Don't be surprised if you had to educate a little bit about why you want to be there. You may have to advocate a little bit that the patient with IDD deserves this care, and the only place it's safe is that hospital. But hospitals, they're hard to go up against, I understand. So, but if you learn a little bit about them and you move right and talk right, don't be surprised if doors do open. Surgery centers. I threw this in there. I don't have any experience working in an outpatient surgery center. I know they're up and coming. According to my anesthesiologist, dentists do work there. I would encourage you to look into these, especially if you don't have a hospital around, or even if you do. These may become more important as they become more prominent. So I think they could be very useful in IDD care. So I throw them out there. I just don't have any experience with them to date. So your role is, I'm going to talk about my role is what I've taken on in anesthesia is largely, and I've taken on these roles because they're the classic surgeon rules. So in the medical world, we are the surgeon as the dentist. So you're going to be expected to do pre-surgical physical, not do them, but obtain them by a physician. Usually it's the person's physician, but be cognizant of pre-surgical physical versus clearance. All of our patients get what I call, well, our paperwork calls it a clearance, but a lot of physicians, don't be surprised if they get really antsy around that word clearance. What you're really asking for is a pre-surgical physical. What are their problems right now? How, what is their current state right now? So if you have a physician kind of balking, hey, would you do a pre-surgical physical for me? You might find they're a little more open to it because they're not signing off whether you can do general anesthesia. That's on you. What you're needing from them is a comprehensive review by a medical doctor. So just be, don't just take, I don't do clearances or, as necessarily a problem. It's more something to be overcome. Pre-ops labs and tests. You might want to start becoming familiar with things like CBC, chest x-ray, EKG. If you have a good relationship with the patient's physician, I know these tests all cost money, but if you have somebody with a history of heart condition, EKG, older patients, you probably should be thinking about labs, especially if you're doing extractions, bleeding times, INRs. I think as the general dentist, you don't have to be an expert in those, but you might want to be familiar with them. Pre-op evaluation. I think you are, as a surgeon, you do have to evaluate your patient before they go under. I think people get in trouble because they don't do enough of that. Again, as a classic surgeon, you're expected to do that. Post-operative care, I'm heavily involved in post-operative care. Recovery versus observation. Of course, recovery is done by the anesthesiologist, but if you're providing anesthesia, you have to do recovery. The board is you cannot leave the office while somebody is recovering. But during observation periods, especially patients with IDD, sometimes they need a little more, like you don't want to send them home yet, but they're awake. That's what we call observation. And I use that word because there's less legal behind it. Also, as a general dentist, I do the follow-ups as the surgeon. That's typical. I resume medications and diet. If you're working with nursing, they're going to want an order to resume medications and diet. You can give that, especially if your anesthesiologist is already gone and done. That's primarily with like nursing home, maybe. AMA, some of our patients don't cooperate with recovery and observation. So I'm a big fan of the term against medical advice. Yes, sometimes have to make a decision on whether they're more of a danger to themselves in observation. Now, of course, you do need to take into consideration where they're going. Are they going to go home, fall asleep, and aspirate on the couch? You may need to deal with complex behaviors during observation. But even here in our facility, we have this as a hard time because even going home, they have nursing coverage, but is it the same as being under our care? So as general dentists, you kind of need to be involved in that. Those are difficult, complex questions. So, well, I went just a little over. I'm sorry I got a little fast there at the end. This is a rudimentary bibliography. It's really more just some papers I've read over the years and reread to come up with this. So this is not comprehensive by any way. Again, I'm not an academic, but coming to the end of the presentation, I'd love to continue the conversation. Here's my email. There was a couple, an anesthesiologist friend of mine wanted me to throw out some, if you want more information and you didn't like the way I presented it, here's a few web addresses to maybe get a little more information. They're pretty good. But that's basically the end of the show for me. I'll see if
Well, Dr. Bullock, that was so informative. Thank you so much. I know I got a lot out of it. I really never even realized there was a difference that we had a dental anesthesiologist or a medical. I just thought it was this anesthesiologist, period. So I learned a lot. So now let's go ahead and open it up for some questions. I've seen a few in the comments in the chat box.
And
I did want to.
I'm having trouble unsharing. Can I just leave that up there?
Sure, we'll take care of it. Yeah.
Okay, I'm sorry about that. Yeah, I'm just having
Yeah,
some
we can
technical
do an
difficulties
override.
here. Not finding. Oh, there it is up there. I can probably do it.
Not a problem.
I'll just leave it up there. But yes, go ahead. I'm
I
sorry.
do. Well, I saw a comment from Ivy Goldstein. Ivy, if you're on, if we can unmute you, if you'd like to say something verbally to everyone and about this HRSA resource that you found.
No, sure. This is at the beginning of the presentation. I posted this comment, just giving you the link to the federal definition for children and youth with special health care needs, and that it isn't specific to children with intellectual and developmental disabilities, that it's much broader.
Okay.
That's all. It was just an FYI.
Yeah, no, it is a very broad definition, yeah, thank you for that, because it is hard. We got to all be on the same page, but there isn't kind of one term that covers everything. But thank you for your comment. Yeah.
Will we have access to the slides?
Yes. Miss, they're going to be up on the website. Feel free to use them as you like.
Thank you.
You're welcome.
Yeah, we'll have those posted probably Monday. We'll have a copy of this recording where you can share it with other people, the link, in case you want others to hear it. And then also probably a PDF of this slide deck as well that we'll have up there. If you'll look in the chat box, are there any other questions? Let me see if there's something else that came up in the chat box. Grisella said when somebody had pneumonia after surgery, I think that was another, when you were talking about pneumonia, people do get surgery.
Yes, they do. Of course, their physician manages that. There's the question of whether you report it to the board or not if they're hospitalized. I have reported, not under the new rules, but I did self-report. It is one of those hard things because like our medical colleagues don't really understand self-reporting like that. They don't have those same rules. And it's hard because like pneumonia is not an ideal outcome for general anesthesia, but it's definitely a potential even for normal people to get pneumonia. And you get pneumonia and your health is compromised and you get hospitalized. Was that direct result of the anesthesia, direct result of the dentistry? I didn't get of course, the board doesn't really, they just kind of came back with, thank you for self-reporting. Well, they didn't say thank you, but it was fine. But, it's one of those things to consider. So well, thank you, everybody. I hope it wasn't too dry. And yeah, thank you. Thank you for having me very much. I really appreciate the opportunity to talk.
Well, and we thank you. It was a very informative presentation, and we really appreciate your time and effort in putting it together and presenting for us today. We look forward to your May 13th presentation. His next presentation will be on special conditions, barriers and challenges, providing dental care to patients with IDD. So thank you again, Dr. Bullock. Have a great weekend. And all of you attendees, thank you for your time and have a wonderful weekend.